Lecture 4 Transcript, Arrest of Descent and Second Stage Mechanics. This fourth lecture is about arrest of descent, but the real subject is the mechanics of a head moving through a pelvis. The second stage invites a dangerous simplification. The cervix is complete, the patient is pushing, and the room begins to watch the clock. 1 hour, 2 hours, 3 hours. The clock becomes louder than the examination. But the second stage is not a clock with a fetus attached to it. It is a mechanical negotiation among uterine power, maternal expulsive effort, fetal head position, fetal flexion, station, pelvic architecture, pelvic floor resistance, fetal reserve, and maternal endurance. Time matters because prolonged second stage is associated with increasing maternal and sometimes neonatal morbidity. But time by itself does not tell you whether the fetus is still negotiating the pelvis or whether the negotiation has stopped. That is the central distinction. Prolonged second stage is not the same as arrest of descent. The second stage begins at complete cervical dilation and ends with delivery of the neonate. In the first stage, the cervix is the central visible marker. In the second stage, the cervix has disappeared from the problem. The central visible markers become station, rotation, descent, pushing, and fetal status. So the question changes. In the first stage, we ask, is the cervix dilating? In the second stage, we ask, is the presenting part descending and rotating in a way that makes vaginal birth increasingly likely, while mother and fetus still tolerate the process? That is a richer question than how long has she pushed. Begin with the anatomy, because the beauty of the second stage is mechanical. GABA reminds us that labor is not a rigid object pushed through a rigid ring. It is the interaction of powers, passenger, and passage. In the second stage, that interaction becomes visible. The uterus continues to contract. The patient adds voluntary expulsive effort. The fetal head descends. The pelvic floor resists, redirects, and helps rotate. The fetal head flexes, rotates, extends, restitutes, and then the shoulders and body deliver. The cardinal movements are not a ceremonial list. They are the logic of vaginal birth. Engagement means that the widest diameter of the presenting part has passed below the pelvic inlet. In a well-flexed cephalic presentation, the widest transverse diameter is the biparietal diameter, about 9.5 centimeters. Clinically, engagement is usually represented by the presenting part reaching zero station, the level of the ischial spines. Engagement tells you something important. At least at the inlet, the head has entered the true pelvis. Descent is the downward passage of the presenting part. It is not continuous. The fastest descent usually occurs in late active labor and in the second stage. That is why a head that was high at complete dilation is not the same as a head that is low, well applied, and already rotating. Flexion is one of the elegant solutions built into labor. As the head descends and meets the resistance of the bony pelvis and pelvic floor, it flexes. With complete flexion, the chin approaches the chest, and the suboccipitobregmatic diameter, about 9.5 centimeters, presents. That is the smallest cephalic presenting diameter. If the head is deflexed, the presenting diameter increases. The same fetus can become a more difficult passenger simply because the head is not flexed. Internal rotation is equally important. Most fetal heads enter the pelvis in a transverse orientation and rotate toward occiput anterior as they descend. This is not just a change in vocabulary from OT to OA. It is a change in geometry. The pelvis is not equally spacious in every direction at every level. The fetal head must orient itself so its widest dimensions negotiate the maternal pelvis correctly. The pelvic floor is not passive. Gabe describes it as a V-shaped hammock that diverges anteriorly. As the head descends, the pelvic floor helps direct the occiput toward the symphysis pubis, or less commonly toward the sacral hollow. It also helps correct asynclitism. The head may engage slightly tilted, with one parietal eminence lower than the other. With contractions and relaxation, the pelvic floor can help the head rotate and become less asynclitic. This is why station without position is incomplete thinking.
Station tells you how low the leading bony part is relative to the ischial spines. Position tells you where the occiput is. Flexion tells you what diameter is presenting. Rotation tells you whether the head is solving the pelvic problem. A head at +1 in OA position, flexing and descending, is not the same as a head at +1 in OP position, deflexed, with worsening caput and no rotation. The station number may be identical. The biology is not. Now define the abnormality. GABA defines protraction of descent as descent of the presenting part in the second stage at less than 1 centimeter per hour in nulliparous patients and less than 2 centimeters per hour in multiparous patients. Arrest or failure of descent means no progress in descent. That definition is refreshingly direct. Protraction means slow descent. Arrest means no descent. But neither should be diagnosed responsibly without asking why. GABA says both require evaluation of 5 factors: uterine activity, maternal expulsive efforts, fetal heart rate status, fetal position, and clinical pelvimetry. Each factor can change the meaning of the clock. If uterine activity is inadequate, oxytocin may help descent. If maternal pushing is ineffective because of exhaustion, analgesia, guidance, or position, changing the pushing strategy may help. If the fetal heart rate is reassuring, there may be time to correct mechanics. If the fetal heart rate is deteriorating, time becomes less available. If the position is OP, OT, or asynclitic, rotation may be the therapeutic target. If clinical pelvimetry and fetal size suggest poor fit, continued pushing may be less likely to succeed. That is the second stage mind. Now bring in the time thresholds. ACOG defines prolonged second stage as more than 3 hours of pushing in nulliparous individuals and more than 2 hours of pushing in multiparous individuals. It recommends individualized diagnosis of second stage arrest, incorporating progress, clinical factors that affect the likelihood of vaginal delivery, risks and benefits of available interventions, and patient preference when time extends beyond those parameters. This is not a command to deliver at 3 hours or 2 hours. It is a command to think carefully at those boundaries. ACOG also says that second stage arrest can be identified earlier if there is lack of fetal rotation or descent despite adequate contractions, pushing efforts, and time. That sentence matters because it prevents the opposite error. We should not deliver only because the clock is long, but we also should not keep waiting just because the clock has not yet reached a formal threshold if the mechanics are clearly failing and safety is changing. The Israeli second stage position paper is especially useful here because it makes station and position explicit. At full dilation, the station of the fetal head should be assessed. Station is determined by the maximum descent of the head during contractions and pushing. Vaginal examination is recommended every 1 to 2 hours and should include the fetal monitor, head station, and head position. Ultrasound can help determine station and position, but the paper emphasizes that intrapartum ultrasound has not been proven to improve maternal and neonatal outcomes and is not mandatory for second stage management. Notice the clinical maturity of that approach. The examination is not just still complete. Of course she is still complete. The cervix is no longer the story. The story is whether the head is descending, whether it is rotating, whether the tracing is tolerating the process, and whether the patient is still able to push effectively. The Israeli paper defines second stage arrest as no change in head station after at least 3 hours of pushing in nulliparous women or at least 2 hours of pushing in multiparous women. It considers the second stage prolonged at 3 hours without epidural or 4 hours with epidural in nulliparous women,
and 2 hours without epidural, or 3 hours with epidural in multiparous women. When arrest or prolongation is diagnosed, a senior physician should evaluate the mother, fetus, and obstetric conditions to decide between continued attempts at vaginal delivery, operative delivery, or cesarean.
Then comes the sentence that protects the patient from mechanical stupidity. Not every arrest or prolongation of the second stage requires immediate delivery. That does not mean delay is always noble. It means time must be interpreted through mechanics and safety. ACOG's outcome data also resist simplification. As second stage duration increases, the probability of vaginal delivery decreases and maternal morbidity rises. Chorioamnionitis, postpartum hemorrhage, operative delivery, and third or fourth degree laceration become more likely. Neonatal data are more mixed, and in several studies, absolute neonatal risk differences were small, approximately 1% or less. But not all data are reassuring. In one large observational study, even after more than 4 hours of pushing, 78% of nulliparous patients still delivered vaginally. After more than 2 hours of pushing, 82% of multiparous patients still delivered vaginally. Those numbers are clinically humbling. They tell us that a long second stage is not useless. Many patients still achieve vaginal birth. But they also tell us that the price of time rises. Hemorrhage, infection, severe perineal trauma, operative delivery, and sometimes neonatal morbidity. The art is not choosing patience or intervention as a personality style. The art is deciding whether additional time is still buying descent. Now, separate pushing from complete dilation. ACOG recommends that pushing begin when complete dilation is reached. The reason is partly safety. Delayed pushing may prolong the second stage, and in a large randomized trial of nulliparous patients with neuraxial anesthesia, delayed pushing did not improve spontaneous delivery and was associated with a longer second stage. The trial was stopped early because of increased postpartum hemorrhage, chorioamnionitis, and neonatal acidemia in the delayed pushing arm. The Israeli position paper is more permissive. It says that at full dilation, pushing can be initiated or one can wait for further head descent. It states that most studies do not show different maternal and fetal outcomes between approaches, so no recommendation can be made regarding timing of pushing after full dilation. But it requires documentation of when pushing begins. This is a real source of tension, and it should not be hidden. The best way to teach it is by separating passive descent from active pushing. If a patient is complete with a high head, dense epidural, reassuring tracing, and no urge to push, some clinicians may allow further descent before active pushing, especially under local practice. But the longer the second stage continues, the more infection, hemorrhage, fatigue, and fetal status questions matter. If pushing is delayed, the start time of pushing must be documented, because thresholds based on pushing cannot be interpreted if no one knows when pushing began. So the resident should not turn delayed pushing into an ideology. Use it, if used, as a documented clinical choice under reassuring conditions, not as invisible time. Now think about malposition. OP and OT positions are not just names on an exam. They are mechanical problems. Compared with OA, they are associated with increased operative vaginal delivery and cesarean. A deflexed OP head can present a larger diameter, apply force less efficiently, and descend with more caput and molding. OT position may represent a head that has not completed internal rotation. Asynclitism means the sagittal suture is not central. One parietal bone is leading more than the other. Any of these can make the second stage long without meaning the uterus or patient has failed in a vague sense. This is why manual rotation deserves respect. Manual rotation is not a trick to do when bored with pushing. It is a mechanistic intervention. The clinician identifies an OP or OT position and attempts to rotate the head toward OA, reducing the presenting diameter and allowing the head to move through the pelvis more favorably. ACOG summarizes several important findings. In a U.S. study of more than 3,000 women with fetuses in OP or OT position, attempted manual rotation was associated with lower rates of cesarean delivery, perineal laceration, hemorrhage, and chorioamnionitis compared with expectant management. The number needed to prevent one cesarean was estimated at 4. In a French study, manual rotation succeeded in 71.7% of OP cases, and cesarean and operative vaginal delivery rates were lower after successful rotation. A meta-analysis showed a modest but statistically significant increase in vaginal delivery when manual rotation was performed for OP fetuses. Factors associated with success include spontaneous labor, fetal engagement, and an attempt after complete dilation but before arrest is diagnosed. That last phrase is important: before arrest is diagnosed. The most beautiful moment to correct a mechanical problem is often before it has become a fully entrenched failure. If a head is OP, engaged, and not yet severely molded with hours of unsuccessful pushing, rotation may convert a difficult second stage into a deliverable one. If the head is high, deflexed, severely molded, and fetal status is worsening, the same maneuver may be less likely to help and may waste time. Now, integrate operative vaginal delivery and cesarean, but only at the level needed for this lecture.
Module 6 will teach operative vaginal delivery in detail. For now, the principle is this: when second-stage arrest is diagnosed, the decision is not automatically cesarean. ACOG suggests assessment for operative vaginal delivery before cesarean for second-stage arrest. Operative vaginal delivery can avoid the morbidity of second-stage cesarean in appropriately selected patients with skilled operators and proper prerequisites. At the same time, operative vaginal delivery is not a rescue maneuver for a poorly understood mechanical problem. It is safe only when the head is low enough, the position is known, the pelvis is judged adequate, the cervix is fully dilated, membranes are ruptured, analgesia and consent are addressed, the bladder is empty, neonatal support is available, and cesarean can proceed if the attempt fails. Second-stage cesarean is also a real treatment, but it is not a trivial one. ACOG notes that cesarean in the second stage carries higher maternal morbidity than cesarean in the first stage, including higher endometritis and hysterotomy extension rates in cited studies. That does not mean it should be avoided when needed. It means the decision should be made with respect for the technical and maternal cost. Now, build a bedside sequence. A nulliparous patient with epidural reaches complete dilation. The head is at +1 station, OA, flexed. She begins pushing. After 2 hours, the head is +2 to +3 with contractions. The tracing is reassuring, and maternal effort remains effective.
This is not arrest of descent. The second stage is becoming long, but descent is occurring. The head is low, aligned, and moving. The correct management may be continued pushing, with reassessment of maternal fatigue, fetal status, and readiness for operative vaginal delivery if progress slows. The time matters, but the mechanics are favorable. Now change the exam. The same patient is complete and pushing. After 2 hours, the head remains at 0 station, OP, with increasing caput. Contractions are adequate, pushing is guided and appears effective. The tracing is still reassuring. This is not just a time problem. It is a position and descent problem. The next thought should not be, wait until the clock says cesarean. The next thought should be, can the mechanical problem be corrected? Is manual rotation appropriate? Is the head engaged enough? Is there evidence of descent with pushing? Is the pelvis clinically adequate? Is continued time likely to produce rotation? Or are we watching caput form without true descent? Now change the tracing.
The head remains high and OP. There is no descent despite adequate contractions and pushing. Recurrent late decelerations appear and do not resolve with corrective measures. Maternal temperature is rising. Now the decision shifts. Continued pushing may no longer be buying useful mechanical progress, and fetal and infectious risks are increasing. This is the setting where delivery should be planned, and the route depends on station, position, operator skill, and safety. If operative vaginal delivery is not feasible or safe, second-stage C-section becomes the correct path, despite its morbidity. Now consider a multiparous patient. She reaches complete dilation, begins pushing, and after 45 minutes, the head has not descended. Because she is multiparous, the room may become uneasy quickly. But the question is still not time alone. Is the head OA or OP? Is she actually pushing effectively? Is the epidural dense? Are contractions adequate? Is the fetal head large? Is there asynclitism? Is the tracing reassuring? A multipara usually descends faster, so absent descent may become concerning earlier, but the same mechanical analysis is required. Now, hold the thresholds in their proper place. ACOG prolonged second stage, more than 3 hours of pushing in nulliparous, more than 2 hours in multiparous, with individualized diagnosis when time extends beyond those values. Israeli prolonged second stage. For nulliparous, 3 hours without epidural and 4 hours with epidural. For multiparous, 2 hours without epidural and 3 hours with epidural.
Israeli arrest. No station change after at least 3 hours of pushing in nulliparous, or 2 hours in multiparous. GOB descent protraction, less than 1 centimeter per hour in nulliparous, and less than 2 centimeters per hour in multiparous. Arrest of descent means no progress in descent. ACOG good practice point. Arrest can be identified earlier if there is lack of fetal rotation or descent despite adequate contractions, pushing efforts, and time. Each number is useful only if the examination is honest. If you do not know station, you do not know descent. If you do not know position, you do not know the mechanical problem. If you do not know whether pushing is effective, you do not know whether the maternal expulsive force has been tested. If you do not know fetal status, you do not know whether more time is safe. If you do not know operator skill and operative vaginal candidacy, you do not know the real alternatives to cesarean. The final synthesis is this. Arrest of descent is not a long second stage. It is failure of the presenting part to descend, interpreted through station, rotation, flexion, contraction adequacy, pushing effectiveness, fetal status, maternal condition, pelvic assessment, and the feasibility of safe vaginal birth. Time thresholds are not decorations. They matter because morbidity rises and the chance of vaginal birth changes as the second stage lengthens. But the second stage clock is not intelligent by itself. The intelligence is in the examination. A sophisticated obstetrician does not ask only, how long has she pushed? A sophisticated obstetrician asks, what has the head done during that time? Has it descended? Has it rotated? Is it flexed? Is it OA, OP, or OT? Is there asynclitism? Are contractions adequate? Is pushing effective? Is the tracing reassuring? Is maternal condition stable? Is manual rotation possible? Is operative vaginal delivery safe and available? Or has the second stage stopped being a useful negotiation and become a risk without progress? That is the beauty of second stage medicine. It is anatomy and time, physiology and touch, evidence and judgment. When you understand that, arrest of descent stops being a timer diagnosis and becomes what it should be, a precise statement about mechanics, safety, and the next best route to birth.